Hello, good evening, good afternoon, good day, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Regan. I'm a professor in Medical Education Research Development Unit at the University of Malaya. We are coming to you live from Kuala Lumpur tonight, supported by Dr. Apajita, who's in New Delhi. I'm extremely grateful to IECHO for hosting the Black Belt Academy program. We are on the brink of going face-to-face teaching in Malaysia because our instruments are being shipped. It's taken a long time to source a set of good instruments that students, I believe, will appreciate the feel and handling of the instruments and learning to improve their surgical skills. I'm hoping this will start in the next 6 to 8 weeks, and on the 6th of September, we are going to have a trainer session at the University of Malaya, and on the 13th of September, another at the Academy of Medicine. This is an exciting time. Thank you very much to you for following, and if it's your first time, welcome. And thank you very much indeed for joining. Tonight, we literally are at the kitchen sink because I want to go through the basis of gowning and gloving and scrubbing up. But first, we go back to the year of 1846, and our would-be hero is a Hungarian doctor named Ignaz Semmelweis. Now, born in Hungary in 1980, Semmelweis graduated from the Vienna Medical School in 1844. He specialized in obstetrics and gynecology and worked at the Vienna General Hospital. Now, in the 19th century of Europe, childbed fever or puerperal fever was an important clinical and public health problem with very high maternal mortality and was thought to be caused by a sort of miasma or epidemicity, or by the will of providence. And apart from bloodletting, there was no cure for it. Now, Semmelweis cared for these women during their illnesses, and when they died, he did autopsies on them to try and correlate the autopsy findings with symptomatology. He also went through analysis of the maternal death records. Now, the hospital had two maternity clinics. The first clinic, all deliveries were done by physicians and medical students. And in the second clinic, all were done by midwives. Now, the maternal mortality in the first clinic was unexpectedly higher at 16% compared to 7% at the second clinic. Actually, this statistic was known by the ladies of the night who were turning up in labor and actually declared they wanted to go to the nurse-led clinic rather than the doctor-led clinic. So, first point, patients actually know. So Semmelweis went through the differences between the two wards and starting ruling out ideas. And the first thing he found is that in the midwife clinic, the women gave birth on their sides, and in the doctor's clinic, they gave birth on their backs. So he had the women in the doctor's clinic give birth on their sides. No difference. Then Semmelweis noted that whenever someone died on the ward, a priest would walk slowly through the doctor's clinic, past the woman's bed, with an attendant ringing a bell. This time, Semmelweis theorized that the priest and the bell ringing terrified the woman after birth, that they developed a fever, got sick, and died. So he had Semmelweis change the priest routine. Again, no effect. Frustrated, he took leave from the hospital from his duties and traveled, and hoped that the break, as often does, would bring about fresh thinking and a new idea. When he returned to the hospital, his colleague, a pathologist, had fallen ill and died. Now, this was a common occurrence at that time amongst on pathologists. And this was a revelation to him that this pathologist at postmortem had very similar signs as the women who had died. In other words, childbed fever wasn't something only women in childbirth got sick from. This was something other people in the hospital could get sick from as well. The pathologist had pricked his finger while doing an autopsy and got very sick and died. And he realized this was the same thing. But it still didn't answer the question, why were more women dying from childbed fever in the doctor's clinic than in the midwife's clinic? And the big difference between the doctor's ward and the midwife's ward is that the doctors were doing autopsies and the midwives weren't. And from the autopsy room, they proceeded directly to the labor room with no cleaning of their hands and delivered babies for the rest of the day. And of course, surgical gloves were not invented yet. And all clinical procedures were done with bare hands. Midwives never did autopsies. So some of us hypothesized that they were cadaver particles, little pieces of corpse that the students were getting on their hands when the cadavers were dissected. And when they delivered these babies, these cadaver particles would get inside the woman who developed disease and die. Now, this is long before Louis Pasteur or understanding germ theory. So he actually said adequate hand washing by the physicians and medical students might reduce transmission of these death particles. And he designed and implemented a hand washing policy for physicians and medical students. And before they entered the room, they were forced to brush underneath their fingernails and wash their hands in chlorine until their skin became dry and the cadaveric smell had gone, because he had noted that chlorine had removed cadaveric smells on floors. So he ordered his medical staff to clean the instruments and clean their hands, not just with soap, but chlorine. And as we know today, chlorine is a very good disinfectant. I'm not sure about the dermatology problems these people had because it's quite a stringent antiseptic. But at the end of year one, the mortality rate in the first clinic dropped to 2.4%. And Semmelweis had established the causality between childbed fever by demonstrating a strong specific temporal association with unclean hands in 1847, without knowing the exact etiological agent. But to Semmelweis' seniors, this was preposterous and totally implausible and incoherent. They doubted the existence of death particles and rejected that their holy hands could be the spreader of death. But with his undiplomatic behavior, he also made more professional enemies than friends in Vienna and had to leave for Budapest and work in a city hospital for the rest of his life. He published a book, Etiology, the Concept and Prevention of Puerperal Fever, in 1860, 13 years after his study. And the book was not welcomed. It was criticized for poor language, unprofessional writing style. It sounds a bit like submitting a paper to a journal today. Semmelweis could not tolerate the criticism and suffered bouts of depression and rage and paranoia and forgetfulness. Actually, the story goes that he was taken out by his colleagues, thinking it was a social event, and they led him to a mental asylum and left him there where he died. Actually, he died secondary to an injury on his hand, and that injury on his hand resulted in sepsis. And ironically, he died of the same thing that he was trying to prevent. Now, his contribution was recognized 20 years after his death as the medical world, as when they became receptive and wiser after germ theory by Louis Pasteur and the concept of sterilization Antisepsis by Joseph Lister. But you could say that Semmelweis is the father of hand hygiene and the father of infection control and the savior of mothers. This story could have saved a lot of lives and spared countless numbers of women and newborns' feverish, agonizing deaths. He was a man of his time. It was the start of the golden age of the physician scientist, when the physician and surgeon are expected to have scientific training and curiosity. So that doctors like Semmelweis were no longer thinking of illnesses as an imbalance of bad air or evil vapors or miasma. Instead, they looked at anatomy. And autopsies became more common. Doctors got also interested in numbers and collecting data. Because we do say, in God we trust, and everybody else requires data. What Semmelweis discovered holds true today. Hand washing is still the most important tool in public health. And I can't help but think of that advert that we have in Malaysia, whose hand are you holding today as you're standing on the public transport system? As we know, before you go to see any patient, not just the patient, but the clinical area, is wash your hands before and wash your hands after. Some of the most dirty things we have around at the present moment are mobile phones, and it astonishes me, even at medical conferences, people take these into the loo and doing all sorts of things, and their dexterity is amazing, texting and peeing at the same time, leaving without washing their hands. Yes, it does happen in hospitals, and yes, it does happen at conferences, despite we saying, wash your hands. Just goes to show, by telling people not to do things is not the way to change behaviors. But there you go. The history of change and stating the obvious, which brings us this evening to gowning and gloving. Well, ordinarily going to theatre, you would put on a hat. And you put on a hat in the same way you go to a public swimming bath, you put on a hat because we don't want the hair clogging up the filters. Indeed, if you've got a beard, you could cover your face and a hat that's a full hat and covers the beard as well. I put there for your reading an interesting Cochrane review about masks and whether masks are effective or not. Plenty of studies are being done. They haven't proven them either way. But I think they're two important things. One, all it does, I believe, is reduce the spittle that happens with most people when speaking. The other thing is, if you've got a cold or cough or sneeze, don't turn to the side because it'll baffle out the back. Masks, when worn for a long time, they get soggy and wet with the humidity, and therefore the barrier, germ barrier, is reduced. Perhaps they should be changed during the operation. Certainly during COVID, everybody was wearing fitted masks. Now they are better, but they're not proven to be any different in theatre. But the other important reason to wear a mask, as stated by the NICE guidelines, is not necessarily that there's evidence that it's preventing spittle or that you are going to get a splash in the mucosal area like your mouth. What it is actually doing is instilling discipline. And I think if you're wearing it as a protection, it's probably best to wear a visor mask around your face in its entirety. But the debate is there, and I'll leave the decision for yourself. So it comes to theatre. We are in our theatre blues. I like the fact that theatre hats nowadays have the name and the role on the hat, and that is very good for team safety and crew resource management. Ladies, I'm sorry, Makeup is a no, and mascara definitely not because it adds to the particles in the air. Jewelry is not recommended at all. Single stud earrings, fine, but preferably none at all. And if you're wearing a ring, it's best that you take it off. Some people prefer not to, but as long as it's a plain band like this, it is easily washable. But if it's got grooves and patterns on it, you cannot wash it very easily. I'm interested to know if when I'm training in martial arts in Aido and Jaidudu, that they recommend taking the ring off because that is now removing you for any external distraction. So you can focus literally on what is at hand. So we start off with hand washing. But before we do that, I'd like to point out two other things. One, nail polish, ladies, again, not appropriate. Two, that your nails should always be generally clean and also sharp, short, such that I don't hear the tap of the nail on the surface. And sadly, the medical students, when practicing percussion, we do it on the table and I listen for the tap of the nail and point out your nails are too long. Secondly, if you indulge in horticulture, car mechanics, or something where your hands are going to get regularly grimy and dirty, I suggest that you wear gloves for your hobbies, such your hands are clean going into theatre. Think about it, you wouldn't go to see a hairdresser if they had really grubby, dirty hands. Now we're ready to go in theatre. In theatre, we have glove boxes, a sink and a trough, and you'll note that all the taps have paddles. You're only allowed to touch the taps once. So we're going to open the tap, and you make sure that the water flow is not too much, not too little, not too hot, not too cold. So you set it at a volume such that when you put your fingers underneath it, it's not splashing out all down the front or over the floor, and at a temperature that's comfortable for your hands. Remember that in hospitals, that the hot water by definition is extremely hot because they want to remove Legionnaire's disease. And if you put really hot water on your hands, it will be uncomfortable. Water and steam pressure sterilization is common for sterilizing instruments because it's cheaper, effective, and safe. That's where you can get high pressures and high temperatures at the same time. So having started our tap, and I'll run the tap just a little bit, we then set the temperature and the volume. We get nail brushes like this, sponge on one side, brush on the other side, but within the nail brush, there's a little plastic scraper. And I love the term, the German name given to it is called a Nagelringer. I like the G, because the G is all the stuff that you've got underneath your fingernails, whether you think they're clean or not. Think of those CSI programs where they're scraping the fingernails for evidence in DNA. And yes, actually, if you're attacked, the best thing to do is scratch somebody because their signature will be under your fingernails. So with a Nagelringer, under the tap, we diligently clean each of our fingernails until such stage that there is no debris coming out from underneath the nails. Now, this only needs to be done at the beginning of the day. It does not have to be repeated unless you've done something really different at lunchtime. It's under both nails and underneath. Both hands and underneath each nail. So the next thing is that we're going to use the brush. And we're going to put a lot of soap on the brush. And we use the brush only for the fingernails. And this should be 30 seconds each time. There are no shortcuts. at all. And make sure as you're doing it, your hand is going forwards and backwards like this, so you're catching the curve of the nail. Forwards and backwards. And rocking your fingernails over the brush. Here. That's 30 seconds. I can rinse that off. I'm going to use some more soap. And I'm going to do it the other side. Another 30 seconds. It's interesting that different surgeons, notice this, put their hats on different ways. It's almost part of their personality trait. But you'll also notice that some surgeons go to a specific tap or set up a specific way. And this is not really unusual because if you think of any sports person taking a penalty at a major football match, there's a pause as they concentrate and visualize what they're doing. And I find that the scrubbing up moment gives me time to rehearse, practice, visualize, and get my mindset ready for the operation. I also sit behind the fusion machine and I can look at the scrub up area and watch people scrub up. And I regularly ask the system to look at my scrub up technique and sign me off for scrubbing up properly. So now we get to the difficult part. The difficult part is that we have to remember that your fingers are going to get cleaner and cleaner during this process, whereas your elbows remain dirty. The water needs to drain from your fingers off your elbows into the sink, not down your front and not off to the side. Now, if the sink is low and you're tall, this becomes difficult and problematic and awkward. And I certainly found that 3 odd cases a day, stooping at a low sink by the end of the day was most uncomfortable. The ergonomics certainly were not there. But I'm going to wet my hands and my own sink, a kitchen sink. This is awkward, shelf, but we'll give it a go. And the first thing I'm going to do is going to use lots of soap and get a nice line. Now, whether you use the pink solution, which is a chlorhexidine-based solution, or whether you use povidone iodine, really doesn't matter for scrubbing your hands. Personally, I preferred povidone iodine because I felt that the chlorhexidine was more like fingernails on the black. You know that feeling. So I'm using the sponge to gently sponge and take off the macro dirt on my forearm. And this is a minute scrub as well. 30-second scrub for each arm. There. Now rinse that off. And you can see bending down and keeping your hands up, making sure that it runs off your hands to elbows. And another reason to make sure I'm not dripping it all over the kitchen floor, because it then becomes a bit of a sink. Now, this hasn't got a lever on it, but I'm using my elbow to pump lather off. But what you want is a very good lather on your hands, a very good lather on your hands. And I'm using the sponge only on the hands to remove macro dirt. There's again 30 seconds on this side. Do not ever use the brush, because the brush excoriates the skin. And if you're too vigorous with the sponge, it'll excoriate the skin as well and increase the bacterial burden. Right. So I have now used the sponge and the brush. Note this adds to the burden of plastic in the hospital. All right, and set off. And I'm going to do the same again, another wash. And this is going to be on the hands, but also hand in hand, making sure that our forearms. Good lather all the way to the elbow. Now I'm going to say that I'm going to interrupt the scrub out technique because I've assumed that somebody's put out a gown for me and put out my gloves. I planned to do that in my head before I started, but I haven't. So I'm going to push a pause on my scrubbing up in a moment, once we're done, and say that I should have opened my gown and gloves beforehand. Now this is a minute washing as well. So far, we've done 3 minutes, okay? Lots of soap, lots of lather. You try not to get it all over the floor, and you try not to get it all over the front. If you touch the tap, that's another wash. I just touched the tap inadvertently there, but if you touch the tap, that is another wash, each and every time. So now we're going to focus on just the hands. Again, a good lather. Now, you would have seen on, turn the tap off for a second, you would have seen on post-its around the sinks, there are key areas in hand washing that you need to address. The palm of the hand, the spaces between the fingers, the backs of the tips of the fingers, the base of the thumb and the wrist, and the side of the hand. Now, I don't mind which order you do this in, but you now got to do another 3 washes on the hand, focusing deliberately on those areas. So I'll hold that for a moment. So I start side, in the back. Then I come to the base of the thumb. And I do it into digital spaces. Backs of my fingers in the palms. And then I do the other side. Side, palms, base of the thumb, between the fingers, side, base of the thumb, and around both sides. Rinse those off, making sure that the water goes from the hand down to the elbow. And you do not touch anything. And we do another. Again, a good lather is required, and in the same sequence. Side of the hand, back of the fingers, side, base of the thumb, coming around the front, with my fingernails, my fingers, palm, between the finger spaces, side again, and repeat side. There's something about the hand washing, that the ritual of the hand washing then helps set the mindset as well. Hand washing is there symbolic. Many literature. Rinse it off thoroughly. Make sure drop it off the elbows. And you can see now, as you contort it in small spaces, that you're already doing a lot of back work. And this should be the last one, another minute. So it's 3 hands, a minute with the sponge, a minute with the hand, a minute with the nail brush, and a minute scraping the nails. And this should be done like this at the beginning of every single day, every single list.
You do that with the elbow. There you go.
Keep my hands up so they dry. So this is where I ask you just to pause because I need to open the gown and the gloves. That is how you wash your hands, all being well. If I come to this side now, on the table, we should have sterile stainless steel trolley, and the sterile drape is put on that, and it's on that drape that the gown and gloves are actually placed. So the gowns, we're pausing, as I say, the sterile bit to demonstrate some important elements of scrubbing. The gowns come in plastic bags, paper plastic bags. Note that this is more waste material. If there is any moisture on the inside of the bag, then it's not sterile. And what you need to realize with these things is that you've got to peel it back. And as you peel it back, turn your hand upside down and gently place the gown on the table. So notice that, peeled it back, inverted it, continued the peeling, and dropped my gown. That is the same method. You open any sterile pack on the wall. You don't drop it from the height because it'll bounce off the table. Similarly, notice for the gloves, again, we're going to peel this back. My hands are soaking wet, so that's why I didn't have done it in the wrong order. There we go. Again, peel it back. You don't touch the inside. You peel it back, you turn your hand upside down, and you continue to gently open it and lay the gloves on the table. You do not drop them from a height. If you drop them from the height, boom, it's off the table on the floor. Now, most gowns come with 2 towels, 1 for each hand. As we go deeper and deeper into that gown, it gets more and more sterile. And I'll explain as we go. So I take the towel and I fold it in 2 lengthwise. The top half of this I'm going to use for my hand. And this is a dabbing, not a rubbing. Remember, rubbing actually excoriates the skin. So I'm dabbing and making sure that our fingers, particularly the interdigital spaces, are dry. So I'm dabbing around the hand. Now, the next part of drying is a common mistake. I take the lower half of this and I place it on my arm. Note that my hand is covering the towel. At no stage is my hand going to touch my forearm because that will desterilize my hand. So I am going to go round and round and dab all the way, rotating my arm so it's dry all the way, and notice one direction. I'm coming down to the elbow and I'm coming off. I'm not doing that. That starts desterilizing, and you should not do that. I'm now going to take the towel and I'm going to drop it in the bin. Okay? I'm not going to scrunch it up, because if I scrunch it up, I'm going to desterilize my hands as well. Same again for the next. I fold it in half. One half for the hand, making sure I'm diving around my fingers and my wrist. Take the other half, again, applying the towel to my forearm, but making sure as I'm drying, skin does not touch skin. And it's one direction, again, to the elbow. To the elbow, I catch the drips off the elbow, and I'm going to discard. I'm not going to scratch. My hands are now clean. They should not, and even when scrubbed, they should not go above clavicle, beyond the anterior pectoral line, or below the umbilicus. They're there. It's interesting that some surgeons walk around like theatre like this, and I think that's a sort of studio effect for Hollywood. The gown comes wrapped. Now, most things, sterile things, again, come wrapped like this. We do not touch the inside. As we go into this gown, it gets cleaner and cleaner. Our fingers are clean, but they're not sterile. Inside the gown, on the very inside, is sterile. And that's the important element. The sterility is making sure you do not touch the gown on the outside. And I'll point out as we go. As we open this up, like we'd open up anything, we make sure that we hold it out to the sides. Okay. And I suggest if you give it a little tug, so it sits flat. And our gown is there. So how do we pick it up? What you're looking at in the gown is the inside of the gown. The inside of the gown. The outside, which is the sterile gown, is folded. So we pick the gown up such that the collar, as you see, is down, and we're holding the spine. And you can place your hands into either side like an oven glove. My hands at the beginning of the sleeves. Now I teach the non-touch technique. In other words, from now on, you should not see my fingers at all. And in this position also, it's important that you have some space around you, because if the gown touches anything, it's rendered not sterile. So you need space. You don't shake your gown vigorously. You're allowed to unfold. So I'm going to let this unfold. And all being well, the tape is going to fall to the outside. I've used this teaching, and these gowns have proven rather awkward because they don't always drop. Oh, there you go. It has dropped with the tray. Finally, there you go. Make sure the tie is on the outside. So my hands now on the sleeve, and making sure I've got space. So my back is to the sink. I'm going to shrug this onto my shoulders. Okay, and it's in this position that you wait patiently, please, for somebody to tie you up the back, to tie up the collar and tie the gown. Okay, to ensure that it's in position. My fingers have not left the gown. In this position, and I'll bring my fingers out to demonstrate, I want you to pinch the cuff of the gown between your index finger and thumb and pinch it firmly. Not too much, not too little. Again, Goldilocks, like that. And fold your other fingers out the way. This is important in putting on gloves closed. And now becomes two of the most tricky parts of gowning and gloving, because we haven't got our digits to help, and we have to maneuver without allowing the gown to touch the table. So the gloves, I open up like a book, so you can read left glove, right glove. And I need to pick up the glove as I open it. Effectively, I'll demonstrate it. The glove is like that. Okay, the thumb's folded across the fingers and the white is the cuff. Now imagine I'm going to now put this glove this way onto my forearm, thumb to thumb, fingers down the forearm. This ensures that your fingers are aligned with the glove. So there you go. I'm going to go thumb to thumb, fingers down the forearm, but the tricky bit is to ensure that you've got a good grip in that pincer grip between your index finger and thumb, and you're holding tight. Because here is the little magic. Because we take the cuff, the anterior edge, and we fold it over. And as we do that, we open the glove up and open our hand into the glove. And I've done exactly what happens for many people is that I'm now going to pull the sleeve. And as I pull the sleeve, I see my fingers are now coming into the glove. All right. So my hand opened up into the glove. Now that's the trickiest part. Even though I've got a little bit of excess at the end, I do not touch it with this hand because this is extremely sterile. I can now pick up another glove. It becomes a little easier because I've got digits I can use instead of pincer grips through a glove. Thumb to thumb, fingers down the arm, fold it over, and open up your hand into the glove. Okay. And sometimes it doesn't go on as neatly as you want it to go on, and it requires practice. Now, I'll give you a little confession that I used to ask the nurse to hold the glove open for me such that I could put my gloves on. There. Now, my fingers are in the glove, and I can touch the glove with impunity and ensure that it sits comfortably on my hands. Good. No stage, apart from the demonstrations, of course, have my fingers actually come out of the glove. Now, I like to have the cuff of the glove across the base of my hand. That feels comfortable for me like that. What I don't want to see is the white of the glove coming out, the white of the cuff coming out beyond the glove, because I think there needs to be that sort of sterile barrier. What size gloves do you use? Well, they got to fit just perfect. I know with the Black Belt Academy, we are doing a summer voice and bare hands, but that's because we want it to be sustainable and you to appreciate the feel. And you'd say that the feel is attenuated by the gloves. Indeed, they are, if the glove is not fitting properly. Two reasons: that the glove is not sitting comfortably on the end of your finger, and there's air in the space. Two, if you pull it tight, you'll find that your finger blanches and actually feels a little bit numb. Again, reducing your feel. So it's a bit like the hot water, too tight, too loose, or just right, and Goldilocks again. And there you have it. We are now gown and gloved. Now, when walking around theatre, the best place to put your hands is over your xiphostomy. As I said before, they don't go above the clavicle, they don't go beyond the anterior pectoral line, and they certainly don't go below the waist. I would not recommend you fold them and put them underneath your arm. That defeats the object as well. You place them there. Now note that your gown is billowing. To actually tie the gown up, there's a little protocol that I am going to give this to my assistant, and I'll see if I can do it by fixing it on something. I fix it at the base of the camera. Ideally, you should give this little wide invitation to somebody to hold. And as they're holding it, they gently turn around and take. This should be in the assistant's hand. Take the other side, and you can tie your gown up. You're ready for theatre. Again, as a new trainee in theatre, do wait for instruction to proceed to the table. Keep your hands in front of you, like this, folded. Be mindful that going through theatre, there are wires, equipment, pipes. Don't storm your way through. Ask some people to clear your path. They will do so when ready. When arriving at the table, if you have not actually scrubbed, prepped and draped a patient before, wait for instruction, holding your hands like this until the patient is fully draped. Then and only then, and by the command of the surgeon, you may place your hand on the table and await further instruction. Gloves are not totally impermeable to injury, and there are many studies that have looked at the gloves after surgery and found holes. Now, since we don't deal with hypodermic needles, needle injuries and cuts are not usually a problem. I say not usually a problem for transmission of disease. I know a colleague, though, he did end up with hepatitis C. But I operate on hepatitis C patients, but I don't double glove. Why I don't double glove is because that removes the feel and accuracy of the instruments. And on one occasion, the registrar was taking a radial artery and double gloving on an hep C patient, and I asked him not to because he wouldn't be able to feel the instrument. He ignored me, and as I opened the sternum, I heard a plaintive cry, "David!" And I looked up, and he had taken the blade straight through the skin into the radial artery, and we had hepatitis C, radial artery blood spraying the theatre. It is your decision, and I'm not going to counsel otherwise, but as far as I'm concerned, I've always used single gloves because double gloves is not part of my normal modus operandi, and I believe it attenuates my field of instruments. It's interesting at the end of an operation, in removing the gloves and gowns, at the end of the operation, you've got to remember now the outside is dirty. And why we wear a gown is one, to protect ourselves, and these are sort of waterproof. Some gowns are not, and if they're not, I'd advocate wearing a plastic apron beneath this, but you'll find that also becomes very hot and sweaty. And as part of the attire that we wear in theatre, and it's a sterile surface. We haven't touched the outside. We wouldn't advocate not wearing masks because actually the public would throw their arms up in horror because the image of a surgeon without a mask is somewhat crazy. It's interesting, in some theatres have a red line policy and others can walk to the door. And I worked in Oxford where one had a red line policy and others where you could walk to the door, no difference in infection. I worked in another theatre where the windows opened onto the cricket green in Bath. No difference in infection. My colleague sadly departed, Ashok used to say that he worked with a surgeon, had the windows open, and he sweated a lot and wore a sweatband, and the doors are open to the outside of the infection. It's really how you drape, prep, and respect the tissues, I think, are more critical to your wound infection than most policies. Suffice to say that the evidence for chlorhexidine prep is better than povidone iodine, and that is overwhelming. But the thing is, I do wonder if that was correct, because most people, when they use povidone iodine, it only works if it dries, and it takes 5 minutes to dry. And I must say, I don't think there are many surgeons who would stand there, gown and glove, 5 minutes waiting for it to dry. I did wait for it to dry. But then I also swapped to chlorhexidine with an applicator that made it easy. And the last 9 years, my median overall wound infection rate was 0. That's for all wound problems, because I only counted the perfect wounds. Now, at the end of an operation, your gown is dirty. Some surgeons have to go, tear it off. That behavior, asked to be undone, and then take the gown off with your gloves in position, and you'll see that your glove rolls off your hand partially. You can take the gown to the side, and it rolls off. Then I can use on the outside, take the gown off, glove off, on this side, put my finger on the inside, take it off, and some surgeons will do that into the bin, showing off. So when and how often do you need to scrub? If you're taking your gown off and glove off because you've got a hole in the glove, or you're taking your break, if you leave theatre, I suggest you need to wash. If you don't leave theatre, it's quite all right to open up a new gown and use an alcohol rub, wait for it to dry, and gown up again. And certainly for a list of lots of procedures, whether it's a short procedure, take your gown off, alcohol rub, next procedure, that's fine. If you leave theatre, I believe you need to do a wash, as I've demonstrated. You do not need to scrape the nails again unless you've done something very peculiar on leaving theatres. Hand washing is vitally important in hospitals before and after you visit any patient area. An alcohol rub is very effective. Simple soap and water is very effective for every day. Every day, when you come in from shops, you've been handling money, handling mobile phones, or holding the rail on the RRT. Wash your hands. It's the best thing we can do as physicians to stop the spread of disease. Of course, with some diseases like Ebola and airborne diseases, PPE and protection becomes a lot more fastidious, particularly with Ebola. And I looked that up online, and the specifications for the gowns and gloves, contact is absolutely enormous. But just bear in mind and just look at the gown, paper, the gloves, plastic there. It's not surprising that we are some of the biggest waste disposal people in the hospital. And there's the challenge for the future generation. What can we do to reduce this waste, maintain costs low, but of course at all stages maintain sterility? I do not have the answer for that, and that's the challenge for the next generation. So I'd like to open this up to conversation from anybody and everybody, and observations and comment. As I said, I think I must have been one of the few consultants that regularly asked the theatre system to observe my scrubbing up technique and sign me off. It's interesting that I think many of us adopt bad habits over a lifetime. And the important thing, as with all things in surgery, is you need to attend to the basics consistently all the time. And that applies to hand washing. So thank you very much indeed for your attention, and I'd welcome any questions. I know two of my senseis, Sensei Chris and Sensei Silai, are actually online, and I'd welcome their observations as well.
Once again, David, thank you very much. A masterclass in how to do it. There's a lot to learn from that, and we can discuss that at a later date. So if you go back to Semmelweis, he was a bit like yourself, and he was quite outspoken, and his colleagues didn't listen to him, and he ended up being driven into a mental institution, and the guards there beat him up, and that's where he got his infection and died from it. But it's about looking at how do you bring about change in any system or organization. And it's about listening to people, not being dictatorial and saying, this is what you got to do. You've got to wash your hands. Because that obviously alienated many of his co-workers and they wanted to get rid of him. So there's a lot to learn there. I'm being a little bit picky here, but when you were demonstrating using the scrubbing brush, you had your fingers down like that. Excellent. But the thumb, what were you doing with the thumb? So the thumb, you need to make sure that the thumb itself, the nail, interacts with the scrubbing brush. The way you
pointed that out. My thumb was at the same level as my fingers.
Yeah, it was hidden by your fingers or protected by your fingers.
And that's because I'm used to doing it, but in the camera, you're quite right, should have pointed it out. My thumb was there, was not ignoring that. So you wouldn't take your thumb separately. It's both together, and that's the brush. And you're walking your fingers back and forth with the curve of the nail.
The other thing was learning about situational awareness and about communication and teamwork. It's very difficult to demonstrate scrubbing as a solo operator.
Correct.
You did manage to hold on to the tag and spin around, but in theatre that's bad practice. And
indeed it is.
Do not encourage your students to do that.
And if I may stress the point that you wait there patiently until somebody could tie you up. The theatre will be very busy at that moment. Patients going to the table, counting instruments, setting up the trays, aligning the diathermy pad, positioning of the patient. That's done by the surgeon. Wait patiently for somebody to tie you up. And as you quite rightly say, it's a two-person job.
The other thing that she emphasized was being taught how to do it and then having somebody observe what you're doing and not to be offended if the scrub sister says start again, because you've made an error which you didn't see and she's brought to your attention.
Correct.
So the immediate reaction will be, oh, no, I didn't. You'll push back against it, but just accept it as a learning opportunity so that you keep doing it until you can't get it wrong. It's part of the basic, the fundamentals of the Black Belt Academy is keep doing it until you can get it wrong. But periodically ask somebody to watch you and give you feedback. And the feedback is there to learn from.
I think I must have been one of the only consultants in the trust that actually ask for that to be done regularly. Because when you're doing something all the time, it's very quickly you can pick up bad habits. And unless somebody is watching and looking for it, you don't actually know when you develop bad habits. I certainly sat there at the
often infection control will do audits in theatres and the surgeons and staff feel very alienated by them being audited because how dare they think that we're doing things wrong?
Well, it goes back to Semmelweis's colleagues who think, how dare you think my hands are not holy? I mean, that is one of the biggest problems that we have in safety in healthcare. And
It's all about changing
humans are,
mindset.
humans are mistake-making machines.
Yeah.
And you can only mitigate that by involving and inviting people to comment on what you do. Indeed. So, what do you think about, Sensei, when you are scrubbing? Do you have a ritual yourself?
Just like you, I'm looking at the operations ahead of me, but I'm planning who's going to do which part of the operation, how am I going to integrate the whole team together. I have a very an overview of the specific operation, but also what's happening in the next theatre and the next hospital. So I have to think outside the box and think about what's happening.
And you're preparing yourself and sort of rehearsing eventualities. Certainly, if I'm scrubbing with a trainee, that's the time to talk about what we do if this happens, what do we do if that happens.
Yeah.
That is what pilots discuss, actually, in the cockpit, and rehearse and discuss potential hazards and problems. But it all makes it, unless you're open and unless you're communicating and unless you are attending to the basics yourself, you can't expect anybody else to.
No. We have Sile on the call, who's an obstetrician and gynecologist.
Yes, please,
Semmelweis
Sile.
was it helped them in changing their practice. So
Exactly.
Sile, would you like to comment for us?
Hello, Prof. Hello, Prof. Chris. Good evening. Yeah.
Sile, you know all about Semmelweis, don't you?
Prof, it's so nice to listen and then so nice to learn, the way that you wash hands and then wear gown, this is a great opportunity to learn from you. I think I have a few facts to raise about that. It's like number one is running water. It's like sometime in a place that where the shortage of water, and it's like some of the tap that it is easily to adjust with the your elbow.
Indeed.
So it's like, yes, yeah. So it's like we adjusted, okay, this will be enough. Then I usually like when we scrub and rub with these, the chlorhexidine and brush time. And I usually off the water because it's like, it's like running water. We don't know how many gallons of the gallon will be of water will be losing. So it's like I used to close back and then we adjust back. It's like, oh, okay, I think this is I want to say about the environmental friendly saving the water for the earth, yeah. And this is one. The second one is the sharing room with the same basin and then opening the gown. So sometimes like I feel like, in some of the theater, they open the gown, and dress up in the area where they wash the hand. Yeah. But sometimes when you wash the hand, some splash of the water, it might go to the open gown, So it's like I want to wear the gown not in the same room where you wash the hand. If you can agree this, yeah. And the third fact is the opening the set. So it's sometimes like in a shortage of the staff, you have to open the gown on your own. So that is a good practice also. You know your size, your glove size and your gown size. So if someone open for you in a wrong glove size, and then you may not like it, so you might want to open another one. So it's like it's wasting your, the resources, So I think I like to open myself, to the correct size of my, yeah. And I'm so sorry. The wedding rings, yeah. Would you like to comment on that? It's like some surgeons, they wear, many years, I never wear any rings, in the theater or in my labor room. Because like, anything that whatever we do good for the patient. So it's like wearing the wedding ring, whether this make different or or whether it can prevent infection or not. But my concept is that we should not wear any rings or whatever. And then cutting the nail, we should, nowadays, the girls, you will notice that it's a long nail and fashionable nail paints, I think it should not be acceptable, So it's like you should cut the nail at least twice a week. This is what we practice, yeah. Then I saw that some surgeons, I'm so sorry, they adjust the gown before they're wearing the glove. So it's like they wash their hand, they put the gown, and then they just adjust the gown with this bare hand, and I was shocked.
Well,
So
that's exactly it. That's why I advocate closed gown, that you should not touch the outside of the gown at any stage.
no,
Because as you
no.
go deeper and deeper into the gown, you get to the more and more sterile element. And as you quite rightly say, you see these people doing this with their sleeves and gowns, you think, no, defeats the object. And you do wonder, well, why can't we and why don't we pick them up on this? So if you've observed it, Prof. Seeley, have you ever said, did you realize you did that? Would you ever say it?
I say, please change. I just gently say that, please change. Yeah.
Please
All right.
change. Yes, please change.
Yeah. All right. Yeah.
And certainly, as a senior surgeon in theatre, I inverted commas have the authority, I suppose, to do that, provided that I accept the criticism myself. But I notice many a bad habit, particularly amongst senior surgeons. I think some of whom become rather lackadaisical when it comes to scrubbing up the tension. And I do wonder, it's a really interesting test, is how many senior surgeons can put their gloves on closed. As I confessed, I used to ask the scrub nurse to hold the gloves open so I could put my hand in, because that way I felt I got a nice tension on the glove and it fitted the fingers properly. But that doesn't mean to say that I can't put them on closed as demonstrated this evening. But
A
glove
lot of
size,
this is about the knots, the non-technical skills.
correct.
So medical leadership is about role modeling.
Yes,
It's important as the senior surgeon in the theatre that you demonstrate best practice.
correct.
You need to be aware of what best practice is and role model that for the rest of your team.
Correct. Correct.
One of the other things was about the ergonomics. So I've been involved in setting up theatres, and there's been an evolution in theatre design. You used to have separate scrub areas, but now with the laminar flow in theatre, you can have you can have the scrub area within your operative area because it removes that aerosol.
Indeed.
Um,
One of the most interesting studies I did.
Sorry about this.
Sorry, not at all. Welcome, young man. One of the most interesting studies I did was I asked a valve manufacturing team in Leeds who were responsible for the clean room and the manufacturing of tissue valves. Now, the pigs were from the Marks and Spencer's food chain and were slaughtered, and only 1 in 100 pig valves actually reached it to a quality where they could start being put on a stent and made into a valve. Now, those valves were then put on a stent, and then a material cuff was put on it, and 20 people maximum was allowed in the room. But the entry and exit were monitored all the time. Particle counts were monitored in the area, and every surface was actually checked for bacteria. Now, this had to be done 24/7, 365, and any breach of that would mean that they could not sell the valve. The valves themselves, the standard was to 6 decimal places. Okay, so I asked that team to come in and do the same particle count, swab count in theatres when I was putting a valve in the patient, because you'd actually think taking a valve out of a pig and putting it in a pot, and then taking it out of a pot, putting it in the patient, most people say out of a pot into the patient would be more sterile. It can't be further from the truth. And I don't think in medicine and surgery, we learn enough about how quality management and infection control in the implant industry, like valve manufacturing, is their bread and butter. They do it to 6 decimal places. Suffice to say that 95% of the areas in my theatre failed 1 decimal place, and 5% of the areas had bacterial counts too numerous to count, including the wash trough, the glove compartment, and the stainless steel trolley from which the instruments were served. And that was because it was used as a vehicle to remove rubbish from theatre. The particle count was extremely high and exacerbated by the anesthetic newspaper and the ink that used to fly off the paper as we turned the paper, but also from mascara and eyelashes. None of that would be accepted at all in a valve manufacturing theatre. So it's interesting and it's astonishing that we do not see
there's a lot that we can learn there from industry. So if you go to a decontamination facility, or if you go to Swan Morton where they're manufacturing blades,
correct.
I mean, the level of microbiology control at every stage is
unbelievable. Unbelievable.
So when you go into theatre, you need to think, how can we do this better?
Every time.
And it's all context dependent. So
Yes.
if you're running a day case facility, it's different to if you're putting in biomaterials, if you're putting in hips and knees. They put themselves into a spacesuit to completely control that environment.
Yeah.
So you need to think about what operations are you doing and how can we do it better?
Well, one of the talks we'll give on the Black Belt Academy is with infection and respect to the tissue, because it's amazing in the different theatres that I've worked. And as Prof. Seeley has said, watching some people do with bad habits growing up, it's amazing we don't see that amount of infection. But then you'd say, are we actually counting it properly? And that raises another question about
rating. We don't see what we don't see, or we don't want to see it.
Indeed.
And we're not aware of it.
So I can't see the questions at the moment in the chat box. Do we have any questions from people, please? Any other people in the chat? Okay, no questions, none at all. We have actually posted in the chat a feedback form. We take your feedback seriously, and would like suggestions from you as well of topics that perhaps we should include. But I haven't quite decided what we're going to be talking about next week. That will be a surprise. I'll chat with my fellow sensei. I've got a couple of topics to cover. I just want to see if it would land properly with the audience. But I'd like to thank my fellow sensei, Chris Cuddy and Prof. Seeley, and thank you very much for joining the Black Belt Academy. Look forward to seeing you again, and we wish you well. Thank you, Dr. Apajita, for production and the scenes, and thank you, the ECHO team, for supporting Black Belt Academy.
Thank you so much, Dr.